Assalamualaikum and good morning. My name is Azzarina and today I will be presenting my research project entitled Efficacy of Fidaxomicin versus Vancomycin for Clostridioides difficile infection, a meta-analysis of double-blind randomized control trials. Clostridioides difficile infection, or CDI, is a major global health concern, causing over 500,000 cases and 29,000 deaths annually in the US alone. Recurrence is common, affecting up to 30% of patients. In Asia, the prevalence is around 14.8%, especially in East Asia. This pathogen forms tough spores that resist disinfectants, making it hard to eliminate, especially in hospitals. It produces toxins A and B, which damage the gut and can lead to severe complications like toxic megacolon. Treatment-wise, Vancomycin is effective but has recurrence rates up to 40% and disrupt gut microbiota. Fidaxomicin, a more targeted antibiotic, has lower recurrence around 12% and spares the microbiome. However, past meta-analysis often relied on open-label studies or indirect comparison, which introduces bias. This study addresses those gaps by including only double-blind RCTs, aiming to provide a clearer, more reliable result. This meta-analysis was conducted with three key objectives. First, to compare the overall efficacy of Fidaxomicin versus Vancomycin in managing CDI by analyzing the clinical cure and recurrence rates using only double-blind RCTs. Second, to assess the incidence of adverse events associated with both antibiotics. And third, to evaluate publication bias using funnel plot and egress tests, as well as determine the certainty of evidence using the GRADE approach. Several meta-analyses have compared Fidaxomicin and Vancomycin in treating CDI. Tashiro et al. 2022 reviewed 6 RCTs and found Fidaxomicin offered lower recurrence than Vancomycin. However, the clinical cure rate and adverse event were similar. Okumura et al. 2020 and Crook et al. 2012 also reported lower recurrence in Fidaxomicin as compared to Vancomycin. Together, this study highlights Fidaxomicin's advantage but also revealed inconsistencies in study design. Notably, Tashiro and Okumura included both open-label and double-blind trials without stratifying by blinding status, potentially biasing results. Tashiro also reported no heterogeneity, which may reflect over-standardization, and conducted subgroup analysis despite that. Most studies came from Western countries, raising geographic bias. Okumura and Crook both relied on outdated trials, limiting their relevance today. My study addresses these gaps by including only double-blind RCTs, directly comparing Fidaxomicin and Vancomycin, and clearly reporting heterogeneity. Understanding the mechanisms of these two antibiotics helps explain their differing clinical outcomes. Fidaxomicin is a narrow-spectrum antibiotic that inhibits RNA polymerase at a unique site. It preserves gut microbiota, reducing recurrence and VRE colonization. Vancomycin, a broad-spectrum glycopeptide, disrupts gut flora more severely, leading to higher recurrence. Risk increases with age, hospitalization, and longer treatment. Resistance is also rising, with higher MICs and declining cure rates. These differences support the need for more targeted analysis, which my study aims to provide. Moving on to the methodology, the study was first registered in Prospero to ensure transparency and avoid duplication. This meta-analysis followed PRISMA guidelines using structured Boolean search strategy combining Fidaxomicin, Vancomycin, and Clostridioides difficile. Searches were conducted using PubMed, Cochrane, and Insightful AI. Only double-blind randomized control trials comparing Fidaxomicin and Vancomycin were included to ensure high internal validity. Studies were excluded if there were open-label, used only one antibiotic, or lacked relevant CDI efficacy outcomes. From each study, data were extracted on clinical cure, recurrence, and adverse events. These were categorized into primary and secondary outcomes in line with the research objectives. Then, all included trials were assessed for quality using the Cochrane risk of bias tools, evaluating key domains such as randomization, blinding, and reporting. For statistical analysis, we used Refman 5.4 under a fixed effects model to calculate pooled risk ratios and risk differences. Heterogeneity was assessed using the I-square statistic, with values above 50% considered high. A p-value below 0.05 was considered statistically significant. Publication bias was examined through funnel plot visualization and egress regression tests using comprehensive meta-analysis version 4. A significant p-value here suggests possible bias. Finally, to assess the certainty of evidence, a grade evaluation was performed using grade ProGDT, rating outcomes based on study quality, consistency, and precision. Together, these methods ensured the analysis was based on high-quality evidence, enhancing the reliability of the findings. A total of 14 double-blind randomized controlled trials were included following PRISMA guidelines. These studies covered North America, Europe, and Asia, improving the generalizability of the findings. Risk of bias, assessed using ROC2, was generally low, particularly in randomization and blinding. However, 5 studies show higher attrition bias due to dropout rates over 10%. Still, restricting the analysis to double-blind RCTs enhanced internal validity and reduced performance and detection bias. The risk ratio for clinical cure was 1.02 with a 95% confidence interval from 1.0 to 1.04 and a p-value of 0.03. This indicates a statistically significant but small effect, meaning that Fidaxomicin may cure about 2 more patients per 100 compared to Vancomycin. For recurrence, the risk ratio was 0.55 with a 95% confidence interval from 0.49 to 0.61 and a p-value of less than 0.00001. This result is both statistically and clinically significant, showing that Fidaxomicin reduces the risk of recurrence by about 12% compared to Vancomycin. Adverse events were mostly mild and comparable between groups, though serious outcomes like renal failure and deaths were only reported in Vancomycin group, supporting Fidaxomicin's favorable safety profile. Publication bias was detected for the clinical cure outcome as shown by Eggers test, where the p-value is 0.0109, suggesting a potential overestimation of benefit. In contrast, no publication bias was observed for recurrence. According to the grade assessment, the certainty of the evidence was rated as moderate for cure and higher for recurrence. These findings strengthen the conclusions made by Tashiro et al. And Okumura et al. And support Fidaxomicin's role as a preferred treatment, particularly for patients at high risk of CDI recurrence. In conclusion, this meta-analysis suggests that Fidaxomicin provides a slight improvement in clinical cure and a significant reduction in recurrence, with both antibiotics showing comparable safety profiles. The strength of these findings lies in the precise methodology, which enhances the reliability of the results. As for recommendation, future studies should focus on high-risk and underrepresented groups, such as elderly patients or those with severe or recurrent CDI. It's also important for researchers to report safety outcomes more clearly and consistently to improve the quality of future comparisons.